It's a great pleasure to welcome you here today. Thank you so much for coming at somewhat relatively short notice. If I may introduce Chapal, and Chapal, forgive me if I try and pronounce your name correctly. Khasnabis?
Chapal is okay.
Chapal, thank you so much. We have had the privilege of being on a panel that Brian Donnelly organised earlier in the year, and it was Brian who very kindly introduces this session. You're very welcome to Fab Change Day. As you know, the initiative is about sharing knowledge and best practice, and we've focused on this COVID period. So we are thrilled and delighted to have you here today because you speak on behalf of the World Health Organization. And in your role as Health Product Policy and Standards Department, with access to medicines and the health products division, I've had a brief glimpse of what you're about to talk to us all about. So if I may, without further ado, I'd like to hand over to you. I'm going to stay on hand. I'm going to come off screen, but I'll be on hand. And if there are any questions, I'll come back in. But thank you very much. You're very welcome, and we're delighted to have you here.
Thank you very much. Let me share my screen first.
Thank you. I think Jenny's popped that up there now. I think you're on your first slide is on the screen, Chapal.
1 second. Okay. Okay. Thank you, everyone. And I'll talk about Tele Assistive Technology, how digitally enhanced care with virtual services can optimize our efforts even during COVID and post-COVID era. So 21st century, the major drivers of health and social care will be aging. I repeat, 21st century, all the health interventions will be driven by aging and age-related diseases, non-communicable diseases in particular, which also include diabetes and stroke. But if you look at these images carefully, then you will see that people here are not having a single morbidity issue or single functional domain issue. It's an issue of multifunctional domain. So the whole health services has to really redesign and revamp, keeping this multifunctional, multimorbidity issue in mind. And we also have to acknowledge that as we age, everyone will need assistive care and technology. So nobody can escape from this. So assistive technology, we say 8.5 billion by 2030 and 9.7 billion by 2050 is the global expected population. So out of this, 1.5 billion people by 2030 and 2 billion people by 2050 will need assistive technology. So keeping $500 cost on average per person, by 2030, estimated global AT market will be $750 billion. And by 2050, it will be $1 trillion. It's a new frontier for job and wealth creation. It is a bit not recognized yet, but with emerging aging population, I'm sure soon people will realize how important this sector is. So realizing this on 4th July 2014, WHO established a GATE initiative, Global Cooperation on Assistive Technology, based on Article 32 of the Conventions on the Rights for Persons with Disabilities, as well as SDG Goal 17 of partnership. And we told everybody, tell us that current reach is only 10%. So how we can reach remaining 90%, and that to a quickest possible time. So see, in 6 years, we have done quite a bit of achievement. We have done organized international conference with German Chancellor, Chinese Prime Minister, or we came out with the priority essential assistive products list. We passed a World Health Assembly resolution on assistive technology. We created 80 scale global partnership for assistive technology, created 80-20-30, where we have also identified 5 key assistive products which needs market shaping and bulk procurement and distribution. And we also created this GATO, the Global Alliance of Assistive Technology Organization. So in 6 years, I think the sector has become more in the limelight than ever before. And why assistive technology? Because previously people were used to stuck with their own sector, own small ghettos. So somebody only in wheelchair, somebody on hearing aids, somebody on prosthetics, like this. But these small numbers was not at all is a big driver to change the global health or public health agenda. So what we did, we tried to combine all these sectors to come under assistive technology umbrella sector. And then we said, look, 1/3 global population will need this, and public health cannot ignore this anymore. And we also reposition assistive products, not only products only for disabled, it's products for public health, it's for all population, and is as important as medicines, vaccines, medical devices, diagnostics, and assistive products. We repositioned whole assistive product as an essential health products. And that opened the new doors for us to now work across WHO and across the world. And we also developed this ecosystem of assistive technology. We say 5P, the people-centered policy, products, personal, and provision. And these are all interlinked. Without one, other is going to fail or collapse. So these 5 key intersectoral arrangement, actually we are pushing based on the UHC Universal Health Coverage, SDG, and Convention on the Rights of Persons with Disabilities, how we can really work together and make sure that people in need have a good quality of life and bring it more as a health continuum. So 21st century healthcare, even today, if you ask 10 people, and most people will say it is preventive, promotive, curative, rehabilitative. And some people will also say it's a palliative. But nobody is realizing that nobody will go from curative to palliative or rehabilitative to palliative overnight. There will be 20, 30 years time in between where people need some point of time, some type of duration, some assistive care. And this whole assistive care is missing from the current healthcare concept. And as people are living longer, and as the family sizes are shrinking, so assistive care is more and more important across the world, and especially in high-income countries. And the life of the people who are especially single are quite. Now we have to make a decision that whether all of us want to end our life to the old age homes or excluded from our family, neighbors, and all, or to be part of it. And if you want to be part of it, then we have to really embrace that assistive care within the healthcare. And that's why we are saying that healthcare of 21st century should be preventive, promotive, curative, rehabilitative, assistive, and palliative. And we also trying to say that all healthcare should be inclusive of assistive technology, and it should be within the primary healthcare. It should not be only at the tertiary level. And try to see that most assistive products, most common one, are available at the single source. Most even today, because of the fragmented sector, people has to go for hearing aid one place, glasses another place, mobility device another place. But older people, especially the people who are single, it's impossible for them to really access these services. One man told me that he takes his wife, he spends 2 weeks of his time to go from one clinic to other clinic to keep his wife active and productive. So this 21st century healthcare or health service system has to be much more different than 20th century healthcare. But to most of places, we are still in the 20th century healthcare mode. And COVID exposed us, COVID told us how backward and how outdated our health system is. Even of the high income countries, people used to think all the problems are in the South, on the developing countries. But COVID told, no, hang on, it's everywhere. So COVID-19 and impact on AT users is tremendous. People who are mobile, who are active, even as they become disabled again due to small repair of facilities or cannot access facilities, or the parents are in the cities, grandparents are with the grandchildren in the villages. So it's a total chaos. Service users, either most of the service facilities were closed down. So this is a big rehab center of Wuhan in China, from where, and or there is a mobility in India. Everybody closed down during the COVID. So where these people could go to access service? And you have to keep it in mind, current available professionals and service delivery system are not adequate to ensure access to assistive technology or any healthcare for everyone everywhere. And COVID-19 exposed this shortfall of current traditional service provision model. I don't dare to say all service provision model, but most service provision model, especially the assistive technology. So we have to really see how assistive technology can be delivered in new normal in post-COVID. So learning from past, in 1960, people developed this telemedicine concept, or telehealth, digital health, has been updated a bit, but fundamentals remain the same. Fundamentals is from hospital to home or community-based care, remote services, and patients and providers are separated by distance, making use of ICT, providers to patient. Nobody really looked. This concept came before iPhone came, but still we are in the same mode and thinking and focusing only on ICT. Time has come, go beyond. And this is what we say, future is digital. And what we call digital health today will be in future known simply as the way we deliver health services in the digital age. So you have to recognize, and it will be, to me, it's a crime if we do not take the advantage of the digital science, digital health, digital technology to optimize our output and outreach. But there's a huge technology divide, digital divide between South and North. And this is where WHO is working heavily with our partners to reduce the gap between North and South, and also to exchange the learning between North and South. People think everything is good in North and everything is bad in South. That's not the case. And aging has shown a lot of good examples in both the sides. So how can we build or connect the bridge between North and South? So if you look, this is the picture I just snapshot took from different continent of the world. And if you look at these pictures, and everywhere you see the person is not alone. There is some family member is around them. But we, the professionals, never recognize that family members is a key player in the service provision, or they can play a crucial role in optimizing the quality of life of the users. So we treated them as a non-formal, uneducated, or unrecognized caregiver. But at the same time, we also seen the technology. And today you have all kind of technology. And I insist we have to look beyond ICT, beyond cloud-based technology. We have to look at the 3D printing. We have to look at the robotics. We have to look at the drone. We have to look at the artificial intelligence. Everything what we have around us to make sure that people get benefit of this. But we are so traditional that we don't take the benefit of all this. So that's what we are coming with a TeleAT model, where we are trying to create a greater balance between the professionals and users, and where we are also trying to make optimum use of the family member and the peer as a caregiver, as a allied health professional, allied service professional, so they can play some role in this whole service provision. So we define TeleAT as optimum use of technology and available human resources to provide and maintain assistive technology at home. So some key features of our new initiative is that improving access, leaving no one behind, making optimum use of technology beyond ICT, computer to mobile cloud-based services, including artificial intelligence, 3D printing, influencing allied and healthcare professionals to embrace more digital technology, telehealth, telerehab, TeleAT, and services from hospital centers to home delivery, more home-based services, task shifting from professionals to the users and family members or caregivers, creating local center facilities. I was just heard the last part of it, our previous speaker discussion. You see, we are saying the same, go local, strengthen the local facilities, family and capacity, use the digital technology to support that local, because that's what only can make the whole health services more sustainable. So what it will include and exclude, we are not saying that we can solve everybody's problem, not a solution for everybody, but majority, at least 70 to 80% problem we can solve with this approach. An essential priority is simpler products, not all products. It should be a complementary, not a supplementary. And you need to develop new generation of products, new generation of services. And I repeat, task shifting, take advantage of artificial intelligence, 3D printing, mobile cloud platform, digitally enhanced care. It's a new way of service delivery to maximize their reach. No one should be left behind. Thank you. So this is our GATE community. So if you want to know more and you want to be in our touch, we have a huge network of organizations and individuals from 119 countries. So if you want to know more about us and what we are doing, please log in and get inside. Thank you very much.
Chapal, thank you very much indeed for a fascinating and an inspirational discussion. I think, if I may, having spent 30 years now in this industry and trying to achieve all that we are, some of the things that you've mentioned, it's extraordinary, the scale of the challenge. I'm going to come back to one of the questions from the audience in a moment, if you don't mind taking a few more minutes. But firstly, thank you for sharing some of your work and some of the statistics. I find, although I've been a member of software organizations in the electronic patient record space and trying to make the best use of technology for over 2 decades, and I've been a CEO of a couple of those companies, my personal passion now is to try and help supply a global health record so that everybody on the planet has the use of that. And I don't mind which supplier supplies it, but I think what you've encouraged there is the use of all technologies, drone technologies, 3D printing. People are very focused on AI and various things. The scale of the situation is absolutely immense, where we talk of 1.5 billion of the 8.5 to 9 billion people on the planet are going to need some support. I think, if I may, it has been a pleasure and a privilege for you to talk about that scale today, because quite often this is been a British initiative around Fab Change, although we involve countries from all around the world. We do think quite parochially. We think about our town, our city, our region, and one of the questions talks about that in just a moment. But my humble experience of the last 3 decades has been that wherever we go in the world, the challenges are not dissimilar. And I certainly believe there is no north-south advantage from the north. And my own personal belief and wanting to travel the world wasn't to go to the conferences, it was to go to the front line of situations, because that is where real innovation has taken place. Early on in this journey, I was talking to your colleague Bernardo at the beginning of March. He asked me to talk to some of your colleagues, and we were looking at some of the African nations where there isn't an electronic patient record. But if we look at Rwanda as a country who has absolutely grabbed hold of technology and genuinely puts a lot of the if you like, developed nations to shame. So it is unevenly distributed. I think what we want to achieve with discussions like this is trying to distribute that knowledge further so people can be more open and more absorbed. Sorry, it's a bit more of a statement and reflection of what I've seen, but I don't know if you want to expand on that a little bit more from your own experiences.
No, what you are saying, that you are right, and the solution is global. We have to support local, but think has to be global. And the problem is somehow people do not look beyond their territory or beyond their country. And I am failing to make them understand that market operates in a different way. You look at how iPhone or Android is doing business. They have the same business in Africa or Asia as Europe. So people, now the problem is the sector operates mostly, especially in the high income countries, they're high margin, low volume concept, and they're very comfortable with it. But what I'm trying to say to them, you will become more useful and you may make more profit if you go with the low margin and a high volume concept. And that's what the mobile phone industry is doing. That's what the cloud-based system is doing. They're not focusing now, even somebody can challenge me. I can tell you one of the biggest prosthetics company of UK, they sold more IP knee, intelligent knee in India than in UK.
Yes.
So the market, that common perception has to change. And you have to, even this hearing aids, I given my favorite example of hearing aids, that no hearing aid should cost more than $100 to an user. And look how NHS pay, how much you pay NHS. And why a hearing aid? All are coming from the same source. I know from where it comes. I know who markets it. I know how. But why a $100 hearing aid goes to $3,000 and $5,000? Why in last 50 years, there is no more than 5.5 companies are manufacturing hearing aids? The whole business was exactly same in the pharma sector 20, 30 years ago. Why don't we learn from the pharma sector that what they did to make the medicines, vaccines affordable and available? And they went global. And that's what I'm trying to break my head. The solution is global. And if we have a global solution, we can be more effective in the local. And the local community in London will benefit as much as local community in Malawi or in Bangladesh, because the problem and solutions are quite identical. And the way internet, especially the mobile phone, is changing the world, so that's the way forward. That's what I try to see. And we are going to launch a new big initiative called Data, Digital and Assistive Technologies for All. So we are trying to marry this digital and assistive technology much more for a global solution. So as I said, I believe in it. Future is digital.
I think, sorry.
That's where we are going to work in future. So most welcome to join.
Yeah, and we absolutely are. I mean, genuinely, as a professional, I mentioned earlier, I started my profession working inside hospitals as a procurement officer, materials manager, and negotiator, those sorts of things. And we were a group of hospitals, and we happened to focus on women and children. So instead of having 45 hospitals that all went and bought women and children's things, they said, well, you be the specialist. And therefore, we shared that knowledge, not that differentiation of price. And I think as a CEO, I've also long been an advocate of open source solutions. And I've wanted to take the fees that we can charge in the developed world and help the developing world. But I have to say, one I've learned from you this morning, but it's also back to the theory, which is the developing world isn't a charity as such. It is able to pay. It's just able to pay at fair amounts. What you've described there, if they can sell $1 million $100 hearing aid solutions, that's much better than selling 10,000 at several $1,000s to people. So there's a lot of sense. There was two quick questions, if I may, but I am fascinated about the family engagement and involvement. And again, as a professional, I've been astounded at how slow the broader adoption of technologies for health and care is compared to the high street and banking. And I know that banking by mobile phone in so many continents now is just a matter of course. I must do justice to our audience. There's two quick questions, and I'm delighted to say that we have our host Roy Lilly and next guest ready to come. So for the audience, we'll be moving there shortly. But to give you the two questions, Chapal, given that 70% of the NHS budgets, this is from Ian Newell, are spent on people with long-term conditions and multimorbidities, how would you suggest the money flows closer to home to care settings and involve multiple disciplinary teams working closer together? Now, I would say that's quite a local question to the UK. However, it may be that actually it's no different from anywhere else in the world.
It's a universal question. It's exactly the same question I hear in Kenya, in Bangladesh, in India, everywhere is the same question. And the answer is the same. I know many people will not like the answer, but still I dare to say the answer. Answer is, it's task shifting. Many things what needs to be done doesn't need to be done by a super specialist or professional. So the answer is we need more generalist than specialist. The more we are going to the specialist, in my early days, we were talking about specialist. Then later we started talking about super specialist. In some countries, I not know. To give a quadriceps exercise to an older person, you have to have a PhD degree with a physiotherapy. Come on, is it needed? So many things, the basic things can be done by the family members, by the immediate neighbors. So the answer is how we do the task shifting, how we can monitor remotely that they are not doing something wrong, because we cannot afford to do any harm. So I am trying to say that how this super specialist or multidisciplinary, whatever you tell this group, they can optimize their service. Instead of one-to-one connection, how they can give 1 to 300, 1 to 500, and think of next generation. In WHO, our DG says, we are 20 million shortfall of the health workforce. 20 million.
It's extraordinary.
So if it is a 20 million workforce shortage, do you think in next 20, 50 years we'll be able to make it up? Which country is increasing more budget for developing more health workforce? No. So we have to be very aggressive and very bold to come with some kind of a drastic solution. May not be the best, but best is the enemy of good. So that at least answer is that how we can demystify, how we can transfer. So I do the specialist thing and I give the generalist thing to somebody else who can do it locally. And that's where the local is so important. And
Chapal,
answer is universal.
sorry, I don't mean to cut you off. We are up against the time. I wonder if our next guest and our host, Roy, would give me one more minute, Chapal, because I've got one really important question for you, which I think will just round us off nicely. From Colin Brown, one of our previous guests, from a World Health Organization perspective, how do we share at least some digitally supported healthcare around the world, not just limited to rich developed countries? If so, what technologies can be shared, political views changes? You mentioned you've got something coming up. Is there something you can give to our audience today to encourage them about this sharing?
Yes, so we are creating a task force. Means if you want to be global, I think there's no other better platform than WHO. If it is health, I mean, it is a global, it's a WHO. So I want your group who are expert, who are interested to this global solution. Please, you have my email address, contact me. We are creating a task force. You know, the inside WHO, the digital health department, health system department, health policy department, and aging department, we are working together. We're creating inside task force, and now we are creating a external task force. So already people like from Norway, Sweden, India are on board. Even UCL is on board. So, and we'll have a consultation in first week of December, how to shape this to take it forward. So any of your members are interested, write to us, and we'll do this consultation in first week of December, because that's how we'll go forward.
Chapal, I can't thank you enough. I think, if I may speak for myself, but on behalf of some of my colleagues, we often see the world as somewhere else. And I have been privileged to travel to 2/3 of the world and seen that actually 95% of people want the same wonderful things for their family and for their friends, and that includes their health and well-being. I thank you so much for joining us today in helping and sharing. And I would appeal to the audience, our local audience, to realize that what you're doing has global applicability, whether you're a supplier or somebody with some excellent ideas. And inviting Chapal to be, I mean, you heard it here first. He's invited you to get involved. This is a small world. It's a global village. Please take that opportunity. We will share anything that comes through. And thank you very much for joining us this morning. I've been immensely inspired, and sorry that we've run out of time, Chapal. I'd love to spend a lot longer with you.
It's better.
Thank you very much. Our next are ready. Thank you so much.
Thank you.
We really enjoyed it. See you again.
Thank you. Bye.